can until you know better. Then, hello everybody. At the outset, I would like to thank the organizers of this conference for so graciously inviting me to speak over here. It's a pleasure to share my work with such a distinguished group of academicians. I am Dr. Gulnar Sethna, an associate professor in the Department of Periodontology at Government Dental College and Hospital, Mumbai, which is the largest dental college in Asia. I teach both undergraduate and postgraduate students, and it's a very rewarding experience that constantly keeps me learning and evolving as I gain insights from my students, just as they do from me. Over the past 3 decades, implant dentistry has become a cornerstone of modern practice. However, there has been a surge in peri-implant complications. Today, my topic, Beyond the Dental Implant, Peri-implant Disease Unveiled, is an attempt to explore the latest evidence-based research and advanced therapeutic approaches for management of peri-implantitis. So these are the contents of my presentation today. Now, before we go to peri-implantitis, it is important to know how do we diagnose peri-implant health. So the absence of parameters like bleeding on probing, suppuration, probing depth, bone loss, these are good indicators of peri-implant health. However, there is a modified definition of peri-implant health, which means the presence of a single bleeding spot around the dental implant. So, Mombelli in 1987 had described peri-implantitis as a disease, and it was at the 11th European Workshop of Periodontology that the classification of peri-implant disease was first reported as a separate entity. So, according to the consensus report of the workshop of the 2017 World Workshop of Classification of Periodontal Disease and Condition, peri-implant disease was classified as inflammatory condition that affects the peri-implant tissues and induced by peri-implant biofilms. Peri-implant mucositis is defined as the inflammation of peri-implant mucosa without bone loss. So here you will see mucosal redness, swelling, bleeding on probing, increased probing depth, and the main feature that you see is you do not see any bone loss. Now, peri-implantitis is a plaque-associated pathological condition occurring in tissues around dental implants, characterized by inflammation in the peri-implant mucosa and progressive loss of supporting bone. So here you're going to see bleeding on probing, mucosal redness, suppuration, increased probing depth, and what we see over here is you see progressive bone loss, which is more than 2 millimeters. Now, in case you don't have any reference points or you don't have your older radiographs, then probing depth of more than 6 millimeters and radiographic bone level of more than 3 millimeters is considered to be a diagnostic parameter for peri-implantitis. Periodontitis and peri-implant diseases are very similar with respect to the pathogenesis, etiology, and risk factors. Dental biofilm plays a pivotal role in etiology of both of them. However, unlike periodontitis, progression of peri-implantitis lesion is, as we see, much faster disease progression, and it is non-linear compared to the periodontitis lesion, which is self-limiting. The inflammatory connective tissue, it spreads more opacally and it reaches the crest of the bone, vis-a-vis the case of periodontitis, where we see that there is a protective connective tissue capsule that separates the lesion from the alveolar bone. There is also an acute inflammatory response in peri-implantitis, which is mainly attributed to the elastase cells which are present over there, and more unpredictable response to both surgical and non-surgical treatment in the cases of peri-implantitis. Now, there's a lot of controversy about the prevalence of peri-implantitis. The studies have shown, the systematic review by Dirks and Tomasi, they showed that the prevalence is around 1 to 47%. And this difference is because of the different thresholds for measuring bone loss in all the studies. How do we classify peri-implant? So the most commonly used classification is that given by Fromm and Rosen in 2012, where it was classified as early, moderate and advanced based on the probing depth and the bone loss around the implant surface. Based on the defect morphology, Monnier in 2019, based on the CBCT, had a classification which divided it into the intraosseous, horizontal and combined defects. So intraosseous means there could be a buccal dehiscence, there could be a 2 to 3 wall defect or a circumferential defect. Horizontal bone loss is the second stage of the classification, and combined defect we have a combination of an intraosseous as well as a horizontal defect. Based on defect severity, Monnier et al. Had classified the defects as slight, moderate and advanced, where slight meant 3 to 4 millimeters of bone loss with less than 25% of bone loss to implant length ratio. Moderate severity meant 4 to 5 millimeters of bone loss with more than 25 to 50%, and in the case of advanced, it was 6 millimeters of bone loss with more than 50% of the bone loss to implant length ratio. So what is the etiology of peri-implantitis? So it is multifactorial. It could be because of microbial, chemical or biomechanical overload. And all these parameters, they lead to bone resorption. So let us see first what is the microbiota in health. So Sokransky's complexes, as we see. So what we see over here in health, we see a predominance of the yellow complex, that's the Streptococcus sanguinis, Streptococcus gordini and Peptostreptococcus micros. So these are the peri-implant, these are the microorganisms which are going to be present in health. Now we see a dysbiotic microbiome when there is peri-implant mucositis. So here we see the orange complex, and predominantly we see the Fusobacterium nucleatum, which is a gram-negative anaerobe which serves as a bridge bacteria, and it facilitates the adhesion of other bacteria. So this orange complex, as we see, it predominates the pyramid that is present. You also see a smatter of red complex over here, the purple, green, etc. Now what we see in peri-implantitis, we see a predominance of the red complex, that is we have Porphyromonas gingivalis, Tanderella forsythia, Treponema denticola. This is very similar to what we see in periodontitis. And but what is different between periodontitis and peri-implantitis? So the total RNA from the microbial communities, it has shown that peri-implantitis and periodontitis, they have similar virulent factors, but there are certain differences. For example, when we see the Prevotella intermedia, now in this what we see is the P intermedia 17, it has type C type of fimbriae. So these fimbriae enhances the ability of the bacteria to be internalized by the oral epithelial cells. Similarly, we have P gingivalis, which has got relatively larger fimbriae present in the cases of peri-implantitis. So these will help in invading the gingival epithelium after it binds to the beta-1 integrins on the host cell surfaces. So you also see the presence of filiform bacteria. These are the Filifactor allosae. These are the bacteria, Candida, Staphylococcus aureus. These are the microorganisms which you see predominantly in peri-implantitis. Now the chemical causes of peri-implantitis are attributed to tribocorrosion and a foreign body reaction, which is predominantly because of the presence of titanium particles. So the potential source of titanium could be either from the surgical phase, where during implant drill placement, or it could be because of the piezo surgery or because of the surgical guide that we are using. In the prosthetic phase, it could be because of the titanium oxide layer loss that takes place, or the mechanism of fretting that takes place, or tribocorrosion. So here the term tribocorrosion, it is used to describe the influence of mechanical force and chemical and electrochemical interaction, which results in the breakdown of titanium. Now, during the maintenance phase, the surface decontamination procedures that we use, like air abrasion, implantoplasty, scaling, chemical decontamination, all these could lead to the release of titanium. Also, it has been speculated that it could be a foreign body reaction or an acute inflammatory response when you are placing an implant, which may lead to complement activation and an immune response cascade that may lead to activation of macrophages, monocytes, chemotaxis, and bone cells. Biomechanical overload. This is also one of the causes of peri-implantitis, and this could be attributed to poor quality of the bone, implant position. Now, classically, we recommend that there should be some space between two implants, because this is to avoid avascular necrosis of the inter-implant cortical bone. So, whenever there is insufficient space, firstly, oral hygiene is also going to be compromised. Also, if a patient has a very heavy occlusal function, that itself might lead to peri-implantitis, and the consequences of this is you will see a screw loosening, there could be a screw fracture or an implant fracture. So there are several risk factors which have to be taken into consideration. These could be patient-related factors like poor compliance, plaque control, smoking, systemic diseases, genetic factors, implant prosthesis, iatrogenic. It requires the surgical skill levels. Also, overheating or the 3D positioning of the implant, that is very, very crucial, and it plays a very important role in the success of an implant. The implant design, material and surface also plays an important role. Phenotype, the periodontal phenotype, the gingival thickness, the buccal bone thickness, and the quality of the bone, all these play an important role. Now, the good news is that most of them are controlled. We also have epigenetic factors which could still play an important role in controlling peri-implantitis. Retained cement, it causes roughness, it favors bacterial attachment and foreign body reaction, and it may result in peri-implantitis. Therefore, it is recommended that the crown margin is at the level of the mucosal margin, providing sufficient access and soft tissue maturation. There are other factors like plaque retentive design. So as we see over here, you see the implant crown has a buccal saddle which extends 2 to 3 millimeters beyond the crest, which may make it difficult to maintain oral hygiene. So you could modify the surface to make it smooth, so that you do not have a plaque retentive area. Does traumatic occlusal force lead to peri-implant bone loss? Well, it shows that there's little evidence to suggest a cause and effect relationship in humans. There have been several animal studies which have shown that there is a cause and effect relationship. However, it has still to be proved in humans. So what is the treatment? So factors such as mobility, clinical parameters like bleeding on probing, suppuration, probing depth, and radiographic examination will determine the course of treatment for peri-implantitis. So if there's a screw loosening, if there's mobility and a screw loosening, you could tighten the screw. If there's a screw fracture, you could retrieve it if it is possible. But if there's loss of osseointegration, you may have to explant the implant. Now, soft tissue evaluation, you have to evaluate the bleeding on probing, probing depth, suppuration. So if you see that the probing depth is more than 5 millimeters and there is bleeding on probing, you have to advise a radiograph. So the radiographic evaluation, based on that, you have the classification as slight, moderate, and severe. So slight is 0.5 to 1, moderate is 1.1 to 1.5, and severe peri-implantitis is more than 1.5 millimeters of bone loss. Treatment protocols are based on the cumulative interceptive supportive therapy, or the CIST protocol, which was summarized by Lang. So the treatment that we follow is still based on this. So since there's no unanimous accepted approach to address peri-implantitis, it is recommended to follow the recommendations of ITI, which has a very logical step-by-step approach. So you have the first step, which is the pre-treatment phase. Step 2 is non-surgical, then reassessment, surgical treatment, immediate post-operative care, supportive care. So what do we do in the pre-treatment phase? We are going to assess and diagnose, see the risk factors which are present over there, and correct the prosthetic factors which are contributing to peri-implantitis. Now, there's an implant disease risk assessment tool which was given by Heinz Mayfield in 2020, where there are eight vectors of the diagram which have to be assessed for finding out the disease risk assessment. So there's in the second stage, you're going to be doing the non-surgical debridement. So what we do over here is mechanical debridement, which is done with the help of separate special tips like the soft tips, peak coated ultrasonic tips. Mechanical debridement can also be done where you can do air polishing for supragingival scaling or subgingival scaling. So here what we can use, as you can see, air polishing with flexible tips for subgingival scaling. Now the step 3 says that after you've assessed the risk factors, you've done the non-surgical debridement, you now reassess it, and after 3 to 4 weeks see whether surgical treatment is required for them or no. So what do we do in the fourth step, that is the surgical treatment, and that includes implant decontamination, second regenerative or resective therapy. So how do we do the decontamination of implant surfaces? It could be mechanical, where air powder abrasive, you use plastic instruments, ultrasonic, air powder abrasive system, or you have chemical decontamination with the help of chlorhexidine, EDTA, hydrogen peroxide, citric acid, phosphoric acid, etc., and laser decontamination with carbon dioxide, erbium mag, Nd:YAG, photodynamic therapy, or LAPIP, that is laser assisted peri-implantitis procedures. So here we generally follow a full mouth disinfection protocol, after which you could do your scaling with titanium curates, plastic curates, or air abrasive. So this is mechanical decontamination. Also, mechanical decontamination can be done with the help of titanium brushes, which are also known as the TN brushes, or you have the NiTi brushes, or the different rotary brushes which are available. So basically they are special wires which are heat treated, so they have more flexibility and have less strength but more flexibility. Chemical decontamination can be done with the help of EDTA, chlorhexidine, hydrogen peroxide, phosphoric acid. You also have blue M, that is sodium perborate. So all these can be used for chemical decontamination. And in the case of laser decontamination can also be done, where special emphasis is given to photodynamic therapy, photobiomodulation, etc. So, approaches. So, what is the surgical treatment of peri-implantitis? Now, therapeutic performances of mechanical or chemical modalities, they seem to be limited due to resistant bacterial strains which are there. So, we may need to do a surgical therapy, which could be either regenerative, where we do GBR, guided bone regeneration, with or without bone grafts, or with the use of enamel matrix derivatives. Resective surgery, which could be either with implantoplasty or an apically positioned flap. So these are the different defects which could be there, and the highest reduction in probing depth that we see and clinical attachment gain that we see are in circumferential defects. So here, if you see, a well-defined circumferential defect could be treated with guided bone regeneration with bone graft and membrane. Now, although circumferential defects, they have the greatest potential for regeneration, but the challenge is in the process of decontamination of these defects. So here we see a class 3B defect which has been treated with guided bone regeneration, and we can appreciate the bone, we can see the bone fill that has taken place after the surgical phase. Now, resective procedures could be open flap debridement, osseous recontouring, apically positioned flap, or implantoplasty. So, open flap debridement with or without adjunctive resective therapy. Here, when you see horizontal bone loss, this scenario is best suitable for implant. Now, during implantoplasty, the surrounding tissues should be protected as much as possible from the titanium particles. So, you should protect it either with a liquid dam, and shaping can be done with the help of an egg-shaped burr, or tungsten carbide burrs are more suitable for doing implantoplasty. So, the consensus report states that surgical regenerative treatment is a predictable option in the treatment of peri-implantitis and in improving the clinical parameters of peri-implant tissues. Evidence-based literature does not support the superiority of a special material, product, or membrane in terms of long-term treatment outcome. A mixture of a xenogenic and an autogenous bone graft is most suitable, and method of implant surface decontamination did not influence the clinical outcome of the procedure satisfaction. Now, after we've done the surgical treatment, we have immediate post-operative care where we may need to give anti-infective therapy, chlorhexidine rinsing, and post-operative antibiotics. So, antibiotic stewardship advises against prescribing antibiotics unless they are indispensable and their efficacy is supported by evidence to combat antimicrobial. So there was a randomized controlled trial which was done on the use of systemic antibiotics, and what was found was that they do help they help in improving the marginal bone level, and there are secondary outcomes are that you see there's a decrease in bleeding on probing depth, and absence of progressive bone loss of more than 0.5 millimeters. However, the potential benefits of systemic antibiotics are not sustained over 3 years. This was according to a study by Karkoak in 2017. So the next step after post-op is the most important step, and that is the supportive care that we have to give the patient. And here you have to clinically monitor the patient, take radiographs, oral hygiene instructions, and professional support has to be. Now, clinical practice guidelines were made for the prevention and treatment of peri-implant diseases. which considered 13 systematic reviews which were evaluated for the quality and strength of the research, and a structured consensus report was made. Now, on the basis of this, there were certain levels of prevention. So, we had the primordial prevention, which was prevention of risk factor development. Then we had the primary. So, here you were prevention of disease onset and risk factor control. So, there's a presence of a risk factor and you're controlling it. The secondary prevention is again prevention of disease recurrence, and tertiary is prevention of disease complications. So both primordial prevention and primary prevention, they are there before the onset of the disease, whereas secondary and tertiary are after the disease onset has taken. It must be rendered. Another important aspect is the significance of keratinized mucosa or peri-implant and adjacent periodontal conditions. So they have said that presence of less than 2 millimeters of keratinized mucosa around dental implants in erratic maintenance compliance seems to be associated with peri-implant diseases. Also, there is a role of a thin gingival phenotype and inadequate keratinized mucosal width of less than 2 millimeters. They may be significant risk factors for peri-implant disease and pain or discomfort during brushing. Now, to explant or not to explant is the question. So, Mish had said that when there's more than 75% of bone loss or less than 3 millimeters of remaining bone contact, critical threshold for implant failures takes place. Counter torque ratchet technique or use of fine burrs, laser surgery, piezo surgery, high speed burrs, elevators, and forceps can be used for removal of the implant. And generally, the CTRT technique or combined is generally the first choice for the treatment since it is less invasive. So, the key takeaways are non-surgical therapy is not effective. A non-surgical therapy of peri-implantitis is not effective in disease resolution. Defect morphology and implant surface will dictate the surgical approach. Resective approach for primarily horizontal and wide defects. Regenerative is used for intrabony and narrow defects. Implantoplasty in rough implants and sites with limited potential for regeneration. And thin gingival phenotype and inadequate keratinized mucosal width may be a significant risk indicator for peri-implant disease and discomfort during. So to conclude, I would like to say, do the best you can until you know better. Then when you know better, do better. Thank you all for a patient listening.